like to thank you for the opportunity that you gave to me to present part of the result of this country case study that was conducted in Haiti. So this study was conducted by me, of course, as principal investigator, together with Dr. Oscar Mojica from Paro, Washington, Luis Richo from Universidad Peruana Cayetano Heredia in Peru, and also Dr. Aloysio Barros from Universidade Federal de Pelotas in Brazil. So as we know, countries all over the world embrace the commitment of the SDGs to improve quality of life of the citizen in 2000. And some specific goals include the reduction of under 5 mortality by 2/3 and maternal mortality ratio by 3/4 from 1990 to 2015. Such commitment inspired the launch of the Countdown to 2015 for Women's, Children, and Adolescent Health. So this movement was known as a global initiative of academics from different institutions in the world in order to monitor progress made in reproductive, maternal, newborn, child, and adolescent health. To better understand drivers for progress in reproductive, maternal, newborn, and child health, the Countdown to 2030, known as a follow-up of the Countdown to 2015 into the Sustainable Development Goals era, commissioned several in-depth case studies in different countries in the world. So as you can see here in this figure, this is a map of different countries in the world from different continents that have already conducted in-depth country case study. By example, you can see here, this is Africa. We have several countries like Ethiopia, Kenya, Tanzania, Malawi, and in Asia, we have different countries like China, Bangladesh, and so on. And in America, so the first in-depth country case study was conducted by Peru, followed by this one now in Haiti. And as you can see in this figure, so in this map, you can see, by example, each domain that the country case study was focused. By example, here in Haiti, we focus on reproductive, maternal, newborn, and child health, but in Peru, it was only newborn and child health. And building on the lesson learned from those country case studies, the Countdown to 2030 is conducting further case studies such as this one that was conducted recently in Haiti. And the objective of this country case study was to comprehensively assess the progress made in birth coverage and equity of key reproductive, maternal, newborn, and child health intervention and outcome from 1990 to 2016, and to explore the main drivers. For that, we conduct a mixed quantitative, qualitative study. So the quantitative approach was based basically on national data from demographic health survey conducted in the country from 1994 to 2016. And the objective was to assess trends in coverage and impact indicator as well as in inequality. And the qualitative approach was basically performed by conducting in-depth interview with key informant, group discussion, and literature review in order to assess whether changes in policy and program were accompanied with changes in coverage and impact indicators. This is a list of all the indicators that we assess in the study. So as you can see, we assess different indicators from different domains, such as from natural disaster, political determinants, socioeconomical determinants, environmental determinants, policy program and financing within the health sector, coverage of reproductive, maternal, newborn, and child health intervention, as well as all the impact indicators. So we use also the standardized tools developed by the Countdown Drivers Technical Working Group to analyze the timing and content of health and non-health policies and programs. We perform time frame analysis for all the indicators, and we stratify all the analysis by wealth index and by urban rural place of residence. We calculate the slope index of inequality as well as the concentration index of inequality to describe trends in inequality over time. And we also use the list approach to estimate the impact of coverage change and nutritional status on child mortality. We estimate the composite coverage index known as CCI, that is a weighted average of the coverage of 8 represented 8 preventive and curative interventions selected from family planning, maternity care, child immunization, and case management of under 5 children. So as a result, we observe that the under 5 stunting prevalence decreased by 40% from 37% in 1994 to 22% in 2016. And in terms of mortality, we also observed that neonatal mortality decreased by 37% from 1990 to 2016. And interestingly is that also the under 5 mortality rate decreased by 54% from 1994 to 2016. And in terms of list analysis, we observed that in terms of neonatal mortality, there was almost no change in terms of what was predicted by list and what we observed in terms of IGMI, but the list predict that under 5 mortality would fall from 104 to 77.6 deaths per 100 per 1,000 live birth from 2000 to 2016, which account for a reduction of 25%. And the main drivers for this reduction was basically oral antibiotic for treatment of pneumonia, the diarrhea treatment with oral rehydration salve, as well as the reduction in wasting prevalence. In terms of inequality, we observe that for under 5 stunting prevalence, we observe more reduction for the poorest subgroup from 1994 to 2016, while for the richest group, there was almost no change during the same period. And for mortality, as we can see here, for neonatal mortality, there were more reduction for the poorest group, while the richest group, there was almost no change during the same period. And we observed a huge reduction for the poorest subgroup, both poorest and richest subgroup in terms of under 5 mortality rate from 1994 to 2016. But very interesting also is that we observed that comparing 1994 to 2016, the inequality tend to decrease for all subgroups. In terms of place of residence, the same picture is also observed. We observe more reduction for those living in rural area, while for those living in urban area, it remained almost the same from 1994 to 2016. And for mortality, there was almost no change for neonatal mortality during the same period, but again, we observe a huge reduction in under 5 mortality rate for both richest and poorest group, for both people living in urban and rural area. This figure here is explore the absolute annual change in coverage against absolute annual change in inequality from 1994 to 2016. So here in this left side, as you can see, those are the indicators where the coverage tend to increase with decreasing inequality over time. And here on the right side, we have those indicators where the coverage increase, but also the inequality tend to increase over time. And interestingly is that we observe the antenatal care with 4 or more visits where the indicator that means where the best performer in terms of increase in coverage and reduction in absolute inequality over time, while the improved sanitation was the worst indicator because it was the indicator which showed the highest increase in absolute inequality over time. But the good news was that the composite coverage index show increase in coverage over time, but with reduction in absolute inequality. And when we assess the policy choice indicator, we observe that to date, the country has only adopted 7 out of the 11 policy choices indicators. So of course, this is a good news because something have changed, but we expect that all of those indicators or of those policy choice indicators should be adopted by the country. So in conclusion, we observe moderate progress in several reproductive maternal newborn child health indicators in Haiti from 1990 to 2016. So such progress have to be praised, although they were not enough to meet the specific goals set by the MDGs, which Haiti also has adopted in 2000. And we observe a perpetuation of inequality over time. So for that, we recommend that multi-sectoral collaboration is necessary in the country in order to achieve the SDGs and reduce health inequality, as well as to achieve the universal health coverage. So we would like to thank the International Center for Equity in Health that commissioned this study together with the Countdown to 2015, as well as PAHO that participate in funding the study, and the Haitian government, as well as the Institute of Statistics and Informatics in Haiti. Thanks very much.
The co-authors are myself and those that you mentioned already. They're affiliated with Vrije University in Belgium, St. George's Core Palliative Care Unit, and of course, Ghent University. And this study was published last year in the Annals of Palliative Medicine. So we are talking about palliative care, so I thought I would include a short definition. And this is from the International Association of Hospice and Palliative Care in 2018. So palliative care is the active holistic care of individuals across all ages with serious health-related suffering due to severe illness, and especially of those near the end of life. And the aim is to improve the quality of life of patients, their families, and caregivers. Medical end-of-life decisions is obviously decisions made near the end of life. Advances in modern medicine can prolong life, including the life of persons with degenerative or incurable illnesses. MELDs, as you would imagine then, are a hotly debated topic because prolonging life of terminally ill patients may not be the most appropriate or desired goal, but rather the quality of their life in the final days or weeks. Communication then, as you would imagine, about end-of-life care and MELDs can be difficult for physicians, patients, their families, as decisions are often perceived as life or death. MELDs can include then non-treatment decisions, such as withholding or withdrawing potentially life-prolonging medications, treatments that are no longer considered beneficial, or it can be the intensification of medications administered to alleviate pain or other symptoms that may have the unintended side effect, for example, rendering the patient unconscious or influencing the timing of their death. MELDs can also include hastening death, such as physician-assisted suicide or euthanasia. There is increasing evidence actually suggesting that appropriate care with low medical intensity near death is associated with more discussions between patients and their physicians about the goals and expectations for medical end-of-life care. Communication and shared decision-making involving patients' input in planning their treatment does promote satisfaction and compliance with care. It improves relationships, and it is increasingly recognized as a quality indicator for care. By resource poor, we mean limited capability to provide appropriate care for life-threatening illnesses, a lack of necessary resources, for example, human resources, facilities, funding, etc., inadequate education and training for healthcare providers, a lack of government support, such as policies, supporting the provision of palliative care, including access to opioids for medical use, and lack of information on the circumstances of dying, aka research. The methods we used were a population-based mortality follow-back study, which is retrospective. We selected a random sample of non-sudden home deaths in Trinidad and Tobago in 2018 of adults who were on an end-of-life trajectory. The information source were death certificates, and general practitioners who certified death was sent a questionnaire via a mail survey. Results. So most responding GPs were male. Most practiced medicine for over 20 years. Most had no formal palliative care training. Communication gained was on the job, and most feel unsupported by the current national protocols of how physicians manage their patients. The next following slides relate to the formal GP training regarding palliative care. So GPs who had received formal palliative care training as opposed to those who did not. This table looks specifically at types of end-of-life discussions. There were no treatments withdrawn, as you can see, but very few treatments were withheld. This table looks at medications in the last 7 days of life. As you can see, no medications were used to alleviate symptoms, but physicians who had training were less likely not to use medications. And when medications were used, morphine or other opioid were more likely to be given by physicians with training as opposed to those without. This table looks at discussions with patients on end-of-life treatment options. The majority of interactions had no discussion. So there were no discussions between physicians and their patients regarding end-of-life treatment options. But again, when GPs had formal training, they were again less likely not to omit patients from discussions. And when discussions were had, they were more likely, again, to discuss with their patients about giving medications to alleviate symptoms. And these were all statistically significant. So let's move now into the discussion. So the most prevalent MELDs, medical end-of-life decisions, were the administration of morphine or other opioid. Withholding artificial hydration and nutrition, although guidelines are ambiguous, foregoing end-of-life treatments like artificial hydration or nutrition could be a cultural taboo in the Caribbean, and withholding treatments may be considered life-shortening by physicians and family members. This might explain the low percentage that was withheld. Now, interestingly, most GPs had no discussions with their patients on end-of-life treatment options, but did include the patient's partner or relative in discussions in most cases, which was over 75%. And GPs involved their patients in discussions in 38.4% of non-sudden deaths, which is actually higher than studies found in Spain, which is 7%, Italy, which is 10%, Belgium, which is 25%, but less than in the Netherlands, which is 47%. The differences in GP trained in palliative care versus non-training were obvious. general practitioners trained in palliative care were more likely to prescribe or administer opioids to their patients in the last 7 days of life. 35.7 versus 11.1%. And they were more likely to give medications, 50% versus 17.8% of when you compare the GPs who were trained in palliative care and those who were not. Also, there appears to be shared decision-making with patients and their family. Sorry about that. So in conclusion then, to develop palliative and end-of-life care in TNT, there needs to be appropriate training for GPs in palliative and end-of-life care. And there also needs to be appropriate policy regarding the necessary regulatory support, such as the introduction of a national palliative care policy. The contributions then of this study, which was actually a series of studies regarding palliative and end-of-life care. This is the first robust research on end-of-life care and the circumstances of dying in Trinidad and Tobago. GPs are the main source of formal palliative care provision in TNT, but most GPs have no formal palliative care training. And discussions about end-of-life treatment options are uncommon. Again, the affiliations are the End-of-Life Care Research Group at Ray University, as well as the Windward Islands Research and Education Foundation at St. George's University. And here's some personal information regarding my email and website. And thank you.
Well, thank you to HSG for inviting me to present today, and also to my collaborators. The majority of them are part of our Health Connect Jamaica network, our central office, as well as to our funders and partners at USAID in Jamaica. So just some disclosure. So I personally received some healthcare funding from ViV Healthcare, otherwise no other disclosures. So I think a great question to start the presentation with is how can the private sector be leveraged to achieve universal health coverage? That is essentially what we will be discussing on how Health Connect Jamaica came to fruition in the first place. So we'll be focusing mainly on access to healthcare services, and then what's the value for money. So a little bit of a background. Where are the gaps in the national cascade? So this is called the continuum of care, or the HIV cascade. It's what's used as a frame for evaluating national responses. This was the figures for Jamaica at the end of December 2019. So the dotted red line across the top shows where the international targets are that we need to achieve by 2025. The blue bars indicate where we're at currently. So you can see that there are two main features where we need specific focus. One is those who are retained in care on ARVs, and essentially what that means is that these clients are consistently going to their healthcare provider, and that they are taking their medication, which is ARVs. And the last one is virally suppressed, which means that the HIV virus has been continuously suppressed by the antiretrovirals, and that is the ultimate clinical target for HIV care. So based on what we're seeing here, and when the program was being designed in 2019, we could see that the quantity, which is retained, needs to more than double, and the quality, which is assessed by whether you're achieving viral suppression, over a tripling of that. So how are we in Jamaica going to be able to double healthcare access and triple the quality? And the answer really is that we can't do it in the public sector. The NGO sector is extremely important for the response, but maybe treatment is not the area of main focus. So let's look at the design of the Health Connect Jamaica intervention. So essentially what we do is we bridge the gap for people living with HIV to access HIV-specific primary healthcare services in the private health sector. So speaking a little bit about two of our guiding principles, one of those is health equity. So meeting clients where they are. Essentially, we do this in two main ways. So we perform a socioeconomic assessment when clients are being onboarded. Those who qualify, and I'll speak a little bit about the tool later and how you can qualify, but those who qualify essentially have no out-of-pocket costs. If you don't qualify, there are significant cost savings, especially at the laboratory, where the majority of the costs are associated in the private sector. And those costs, depending on where you go, can be upwards of 80% health savings or cost savings. And the other way that we do that is we provide key population friendly. So those main populations or subpopulations which are at risk for HIV, men who have sex with men, commercial sex workers, transgender population, the services that we provide are tailored to their individual needs. So as you can see on the top of the picture, everybody gets the same bicycle regardless of who they are or their needs. But at the bottom, which is what Health Connect Jamaica does, is we tailor the intervention based on the requirement of the population. So the other guiding principle is North Star decision making, and I speak to the team about this almost every day. So we have a human-centered or client-centered approach, and we integrate that in our overall programmatic design. We look at it in our daily implementation decisions, and then we also ensure that we get client feedback and we adapt the model moving forward based on the responses. So the basic structure of the Health Connect Jamaica model is we have a steering committee. That steering committee is chaired by the Permanent Secretary for Health, as well as other non-governmental and governmental agencies are a part of the committee. So we have a coordinated response, and we ensure full integration into the national HIV response, and we're not considered just another vertical model, but we are an integrated component. The next step here, as you see, is the coordinating unit, and that's the hub. That's where we perform most of our functions. It's the backbone support, essentially, of the network. And then we have clinical providers, so those can either be doctors, psychologists, and then we have laboratories and pharmacies. So the contractual relationships that exist, we have a cooperative agreement with USAID and the University of the West Indies. So the Health Connect Jamaica project is housed in the Faculty of Medical Sciences at UE. Then we have MOUs with the Ministry of Health. We have outstanding, awaiting to be signed MOUs with social protection agencies, as well as the National Health Fund. So NHF is where the drugs are managed. And so we are awaiting our contract with them. And then we have service delivery contracts with clinicians, labs, and psychologists who exist in the private sector. One of the cool features of the Health Connect Jamaica model is our reimbursement system. This is how we control for healthcare costs, right? So fee for service for clinician services are known to be inefficient, and there's no control for quality. So what we have is a capitated payment structure, as well as incentivized payments, which we call pay for performance payments. All of the other partners are paid as in a fee for service model at the moment, with no additional incentives. The agreements with the pharmacy, we don't have direct contractual relationships with the pharmacies. The private pharmacies have already been contracted under the NHF to deliver and dispense antiretroviral drugs, which are the HIV meds. So the other feature of the model, which allows us for rapid expansion, is this hub and spoke model. So if you kind of compare this to a public health system, where you have a clinic, so you have infrastructure, then you have to outfit the clinic with all of your HR components, and then you have to service the patients that you're seeing. With this model, what we do is we have existing clinicians and laboratories in the private sector, so there's no infrastructure investment. We perform all of those sort of backbone features and functions, as I mentioned earlier, so admin, finance, monitoring, evaluation from that central hub. Our psychologists are able to provide services because the majority of them are performed over the virtual platform. And so we're able to have national expansion and national coverage very rapidly. We also perform case management and contact investigation. So two key functions for the sort of supportive clinical services along with the doctor. So when you think of an HIV clinic in the public sector, you usually have a myriad of other human resources available. So adherence counselors, the same case management, social workers, etc. Whereas in the private sector, it's without Health Connect Jamaica, it was just you and the doctor, right? So we provide those supportive functions from within the unit, which is how we're able to provide them nationally without having to build any infrastructure. The other feature of the model in Hub and Spoke is our laboratory network model. So in the hub, or the central unit, is the National Public Health Lab. And then in the spokes would be your private laboratories. When we did our baseline investigations for the development of Health Connect Jamaica, we realized quite quickly that the lab cost was the highest cost that the patient would be paying for out of pocket. So the way that we control for costs is we don't process samples at the private lab. We contract the private labs to do what we call our phlebotomy and transport model. And so the client interfaces at the private sector, which is what the client cares about. They want to interface with the health system and the private sector. And then we transport the samples to the National Public Health Lab, where they are processed at a much reduced cost. Health Connect Jamaica then collects the results and enters them into our electronic system so that the clinicians can have access. And then we also pay the National Public Health Lab. So in this way, we are funneling international donor funding directly back into the public system to allow them to do capacity strengthening. So that's one of our main support systems. So just to outline very quickly what our service delivery process is, we have an online reservation application, which I'll speak about, public sector referral and other partners who refer patients. So that's how we get patients to be onboarded. We run assessments, so either social needs, their contact tracing and contact investigation, their baseline laboratory assessments and the psychological assessments are done. And then they're referred to the clinician who provides the services. The psychologist will provide their psychotherapy. And then we also review all of the clients who are unstable. So you're not virally suppressed, you've been missing appointments, etc. And we review those in a multidisciplinary team. Sorry. Secondly, we really focus a lot on technological health solutions, right? So the online reservation application, which I mentioned earlier, this is a portal where clients are able to go online and book services directly. We also use it for our case management, so the case managers can hold the hands of the clients throughout their entire treatment process. And we can track when they have collected medications, when they have seen the psychologist, when they've seen the doctor. It also provides a function for contact investigation. So the Aura system sends out anonymous text messages to sexual partners of contacts. The sexual partner is then alerted of their potential exposure. They're directed to a link to book online and book for an HIV test. The other electronic system that we use is called the TSIS, Ministry of Health and Wellness's Treatment Services Information System. So we deploy that system throughout all of our partners. And that is the way that we're able to seamlessly feed data directly into the national system. So marketing, all of our marketing is direct-to-consumer marketing. So we use social media, we use SMS blast text messages, and we also have traditional media, so television and radio. This is all direct-to-consumer, as I mentioned, and we direct all of our clients from those messages towards the Aura platform to book services. Okay, so a little bit about the results. So here's a map showing all of our locations of services. So we have 44 doctors onboarded. Those are indicated by the white cross. And then the blue pin, sorry, the red pin is the 31 locations for the lab. So you can see that we have a pretty wide network after 1 year of implementation. So here's a cumulative onboarding. So the red line shows the number of patients or clients that we've onboarded, and then some key milestones are also indicated. So September 2019, we received PEPFAR, or the President's Emergency Plan for AIDS Relief, approval for the project. As we are a University of the West Indies project, we get the MONA Research Ethics Committee approval in March. We launched to the public in July of 2020. We secured our second year of funding in September, and then we became a full implementing partner, which is a significant upgrade in your projects under the PEPFAR platform. And at the end of September 2021, which is our first full year of implementation, we had 314 clients. And just to show that up to December, we've been continued our expansion to over 400 people. So in terms of our male to female ratio, they're pretty equal. Interestingly, in the age distribution, a third of our patients are over 50. So in HIV, those are called the aging population. So we're usually 10 years younger than non-HIV infected persons in terms of the kinds of chronic and comorbidities that you would see in non-HIV patients. So a third of our people have increased needs just based on their age. Now, the reimbursement status, as I mentioned earlier, we have an assessment tool that we use which assesses per capita household income. And we use the WHO definition of a catastrophic health expenditure which is greater than the 10% threshold, right? So if the healthcare costs that would be provided, not in the private sector without Health Connect Jamaica, but this new much reduced fee structure of Health Connect Jamaica, if that cost is greater than 10% of your per capita household income, per capita household consumption, then you would qualify. One of the main myths that existed is that people who are accessing care in the private sector were wealthy. And that is not the case at all. So what we found is that over 80% of all the clients who were referred for assessment qualified based on this tool. And pre-existing clients, so clients who were seeing the private doctor before they were onboarded to Health Connect Jamaica, 60% of the clients, of the pre-existing clients who were assessed qualified based on this rule. So we can see that there's a very great need for this supportive financial support for accessing care. Now, in terms of our sources of onboarding,
give you about 1 more minute to wrap up because we were giving each individual about 15 minutes, and let's give you about a minute and a half to wrap up, please.
Sure. So pre-existing clients, as you can see, is the largest number. Here's our treatment cascade. Most of the patients are being dropped off between engaged in care and viral testing, so we need to increase this, getting the number of people who are accessing their testing. 90% of people who are presented to ACJ are linked, and then 97% are started on ART within the first 2 days of seeing the doctor. So that results in a 60% viral load coverage, 91% viral suppression. This slide basically shows that of the 97 people who presented to us as unsuppressed, transitioned, only 13 individuals remained as unsuppressed, and the other 66 were transitioned into viral suppression. When asked for patients who were previously lost to follow-up from the public sector, 3/4 of them chose to come to Health Connect Jamaica rather than returning to the public site. And we were able to achieve an 84% suppression in those clients. As I was mentioning, we have a satisfaction survey. So 96% say that they would come back to us. The main reasons were staff friendliness, confidentiality, and privacy. And we also have gay men, persons who paid for sex, and persons of trans experience. So in finalizing, our impacts really are around health, universal health coverage. So we have private sector integration and an equitable financing model. And in terms of our health system support, we support these obviously under service delivery, the health workforce, the health information system, and financing are the main. And that's it for me. Thank you.
Very much, Dr. Graves and Chair, and appreciation to the Caribbean Center for Research and for hosting this conference, and also for Health System Global for accepting this paper. As you indicate, it's a collaborative paper that look at lifestyle risk factors in breast cancer patients at the Oncology Clinic, Georgetown Public Hospital. The need to get the screen change. The background to this whole study, that in 2018, the WHO reported breast cancer deaths in Guyana in 75 deaths, which represents 1.26% of total deaths. The adjusted death rate reflected 24.36 per 100,000 in the Guyana population, and which ranks at number 20 in the world. Locally, breast cancer is ranked as number 2 after prostate cancer as the most common form of cancer in Guyana. Some of the issues, late diagnosis, side effects of therapy, which also cause other types of cancer, and which also result in reduced survival rate of these patients. So what is the motivation for doing such a study? As we know, the statistics is there with respect to breast cancer. An assessment of the risk factors using the collaborative approach, and you'll see that the model which I would have chosen, so that we can address this issue of breast cancer. It is somehow believed that assessment of available screening tests and known risk factors of breast cancer can contribute to enhancement in care and its prevention. Prevention of breast cancer, one of the major ways in which we can tackle breast cancer is focusing on lifestyle factors. We know that genetic loads the gun, but lifestyle pulls the trigger. And so we cannot make a lot of adjustment with respect to, we couldn't choose our appearance, but certainly we can choose our lifestyle. And this somehow can make a major difference with respect to the prevalence of breast cancer. The objective of this study was to identify lifestyle differences between women diagnosed with breast cancer and women with health at the Oncology Clinic at the Georgetown Hospital. Now, oh yes, I missed this. The sub-theme, the theme which I've used is the intersectoral collaboration and integrative governance on the road to health care in all policies. Now, equitable approaches to address healthcare disparities require responses from and coordination with other sectors. And so you will see that when we look at the risk factors with respect to breast cancer, a lot has to do with the disparities in healthcare. A lot has to do with respect to the approach in which we try to look at these factors. We feel like breast cancer is just an issue of the healthcare sector. However, by looking at that intersectorial approach, and that is what I'm arguing for here, so we can have a policy where at the national level and even international level, where it involves all aspects, the social protection, education, health education, trade and agriculture. You know, a lot of the issues of cancer has to do with the chemicals used in agriculture. The issue of transportation, the manner in which you know, vehicles and they give off a lot of toxic chemicals, which in the exhaust, which are associated with cancer itself. And so the intersectoral collaboration, looking at all aspects of a diet from an agriculture's perspective, in terms of from social protection in providing equity among women with respect to that are vulnerable to the issue of cancer, and also in education. At the level of the schools, we start at a very early age in educating our young women as to the factors and the risks of developing breast cancer. And so I think, as much as you look at the data, there's so much of studies that are done all over the world. Every year we go and we say, yes, these are the issues. But have we ever thought about having this intersectoral approach of really trying to address it from all angles? And that is the case in which I'm trying to make a point here. Now, as I mentioned, the objective of this study, looking at identified lifestyle differences between women diagnosed with breast cancer and women without breast cancer at the oncology department. Now, this study was an analytic quantitative case control study that sought to evaluate lifestyle factors in patients diagnosed with breast cancer at the Oncology Clinic at the Georgetown Public Hospital. It involved two groups, the case group and the control group. The case group consists of 68 women who were previously diagnosed with breast cancer and members of the clinic between January 26 and 2019. Now, I must tell you that we ended up with 68 women, but when we approached the oncology department, we were given a list of 200 women that were diagnosed, but we could have only located 68 because all the other women would have already died. And I did spoke earlier about late diagnosis, about one of the issues that we have with breast cancer. We cannot diagnose breast cancer early enough. By the time we diagnose breast cancer, the women are at stage 4. We're looking for a lump in the breast where we should be doing biological markers. We should also be looking at the multisectoral approach of prevention and promoting healthy lifestyles, looking at all sectors which can contribute to a reduction in these issues. The control group included female patients, age-matched control, that were taken from the outpatients department who had no past medical history of any breast cancer or any breast pathology and did not present with any signs of symptoms of breast disease. Now, in terms of our data, a summary onto the variables in which we were, investigated, we classified them into two categories: those that were demographic and those that were lifestyle. Now, our focus, we cannot make much, the demographic data, your age, ethnicity, socioeconomic status. Of course, not merely, but socioeconomic status can also be lifestyle as well. Your BMI, chronic illness, underlying family history. And then we have, in terms of lifestyle, your education, employment, your marital status, number of children, use of oral contraceptives, using of freezing plastic bottles. There is a lot of study that have done with respect to PCBs which have been isolated in breast cancer tissue and has been associated with breast cancer. The use of fast foods, we imported fast foods and we imported disease, smoking, alcohol, exercise. And so those were some of the factors, the lifestyle factors, which we think, and when you look at the lifestyle factors, it encompasses not just health, but it involves agriculture, it encompasses social protection, your marital status, your socioeconomic factors, exercise, physical education. We need to have a policy to promote physical education. A country like Guyana that is involved in, with developing housing schemes and all of that, but are we putting these facilities in the neighborhood so as to promote physical activity? We need a policy to do that. When we look at the results, what we came up with 4 factors that showed significant difference using the univariate logistic regression with and without propensity score adjustment, right? And so we have with propensity score adjustment and without. And we saw there were 4 areas, there were 4 variables that showed significant difference among the group. And that include the use of whole wheats. And of course, that's the case of complex carbohydrates, employment, using of food that is frozen in plastic, and stress. These were the 4 factors that lifestyle factors that showed positive diagnosis to risk as indicated: employment, stress, and of course, not being unemployed alone can also contribute to stress. Whole wheat diets and use of freeze plastics. And this is a new evidence. This is something which we have infused into the study based on what some of the in terms of the chemicals which have been associated with respect to cancer in general. And as I mentioned earlier, that PCB has been isolated in breast cancer tissue. And as presented, results from adjustment methods were similar to those of the unadjusted method. All notable relationships are inverse, meaning that diagnosed patients are less likely than non-breast cancer patients to be employed, experience stress, use frozen plastic bottles, have food stored in frozen plastic bottles, and consume whole wheat bread, whole wheat diets because of the cost. For women with breast cancer, the study showed that Indo-Guyanese had a positive family history, despite this group representing half of the study population. Afro-Guyanese women, followed by mixed race, had the highest number of persons with a positive family history. The latter findings correlate with other studies that were done by Sierra et al. In 2018. Therefore, the need for breast cancer, even as we consider those risk factors that have been identified. And so this brings an end to the presentation. And as I would have indicated, that the whole issue of intersectoral collaboration, that is a policy which, based on these studies and similar studies, if we to have that sort of a policy, I think we can go far away in reducing, in making, or reducing the risk of persons being exposed to these lifestyle factors, which contribute to breast cancer and certainly can make our women much healthier, and we can reduce the risk and increase the life expectancy even of patients diagnosed with breast cancer. Thank you very much.